All right. Welcome to chapter 23, management of patients with coronary vascular disorders or coronary artery disease. This is a big one. This is where a lot of content from unit 3 comes from. So coronary artery disease mainly is attributed to, well, two major things really. Atherosclerosis development and also what's called arteriosclerosis development. So atherosclerosis is a normal accumulation of lipids, usually or triglycerides and other kind of fatty substances against the endothelium of a blood vessel, specifically an arterial blood vessel. This is the common main cause, pathophysiological cause of cardiovascular disease. Because atherosclerosis, when you see these plaques build up, they call them plaques, these big buildups of lipids and stuff like that. It goes hand in hand too with hypertension and other conditions that cause issues. They all kind of correlate with each other. Smoking, diabetes, injury to the blood vessel makes this endothelium not smooth anymore. And when it's not smooth anymore, it has potential to accumulate cells and the fatty plaques. So they kind of all go hand in hand. This basically begins typically with vascular injury from hypertension. So theoretically, you could have high cholesterol, but not having hypertension will make you less likely to suffer from a coronary event. But if you combine hypertension that happens usually with age plus high lipids like high triglycerides, high LDL, the cholesterols, then you get atherosclerosis, this buildup of plaques, and that basically closes down the lumen of the blood vessel and makes blood flow less. Typically, again, the patho is that because there causes injury and inflammation, the plaque starts to build up. Then white blood cells get involved, like macrophages and neutrophils try to swallow and ingest, and then they kind of form these what they call foam cells, and they just build up around that area. And then posits, they call them atheromas. Atherosclerosis produces these plaques they call atheromas, and then you get acute coronary syndrome, myocardial infarction. Arteriosclerosis happens usually hand in hand with this. They are two separate things, but they pretty much never happen exclusive to one another. Because they kind of cause one another in a sense. Arteriosclerosis is the artery wall thickening and the endothelium getting tougher, and this would be a direct response to hypertension or chronic blood vessel injury, like you see in diabetes. So that arteriosclerosis usually is in combination with atherosclerosis. They kind of happen simultaneously. You need to know the modifiable versus non-modifiable risk factors for coronary artery disease development. These are very similar to the development of hypertension, but hypertension and diabetes are also part of this. So you need to know these. Need to. So age, usually starting around age 55 and older. Men, as far as gender, tend to develop coronary artery disease more than women. Race, it is higher in African American populations than it is in other populations. That would be neat to know because that comes up. Something called metabolic syndrome, which is part of an extreme case of type 2 diabetes where increased insulin resistance, there's central obesity, around the waist, high triglycerides, high LDL, hypertension, high fibrinogen found in the blood, all makes it more risky. So diabetes, obesity, high lipids, hypertension, smoking, alcohol, poor diet, lack of physical activity, increased physiological or psychosocial stress, all are modifiable risk factors. You can change how well you control your diabetes. You can change your weight. You can change how much you exercise. You can quit smoking, quit drinking, get your blood pressure under control, change how much lipids you have, change your physiology, and change your lifestyle to modify stress. But you cannot change your family history of heart disease. So genetic predisposition, you cannot change your ethnicity. If you're African American or other, you have a higher incidence. You can't change your gender, and you can't help aging. So those are all non-modifiable risk factors. Know the difference between the two. So prevention kind of goes into those: cholesterol management, stopping tobacco, managing our high blood pressure, managing our glucose, weight, physical activity, hypertension management. So how does this manifest itself? So coronary artery disease typically always manifests itself as ischemia to the heart muscle. So the heart muscle not getting the blood flow it needs, causing the cells to be deprived of oxygen. The cardiac muscle, the myocardium, is very, very, very sensitive to oxygenation. And so this is going to cause damage or death to the cells, physically damage the myocardium, eventually probably cause scar tissue, which leads to other cardiac dysfunction like dysrhythmias and heart failure. So the manifestation usually is called angina of chest pain. So angina typically refers to chest pain. The technical name for it is angina pectoris. Pectoris as in chest and angina as in pain. Angina itself just means pain, but typically when people talk about angina, they're referring to the cardiac time. They're referring to angina pectoris. But angina, death to cardiac cells, MI, sudden death from an MI, those are all the things that this can lead to. So what is chest pain really? Angina pectoris. This is just angina pectoris they use as the title for a clinical syndrome characterized by these symptoms of chest pain and pressure related to cardiac dysfunction, related to cardiac ischemia. So there's types of angina, and these are need to know. So the big need to know here is stable versus unstable. Stable is predictable and consistent pain that occurs on either exertion, like exercise, gardening, climbing a flight of stairs, and is relieved by rest or medication like nitroglycerin, the vasodilator. Unstable, also sometimes called pre-infarction angina or crescendo angina. Symptoms increase in severity over a period of time and may not be relieved with rest or medications like nitroglycerin. That's the difference between unstable. And unstable is considered, like, again, pre-infarction, crescendo angina. It's a precursor to having a heart attack, having actual tissue ischemia with actual myocardium cell death. That is what unstable. So unstable is like we're having a heart attack or we're about to have a heart attack soon and needs to be addressed. And also unstable angina may or may not be triggered with physical activity. It may just pop up. Unstable angina may wake someone up in the middle of the night. That is unstable, whereas the stable is usually triggered by physical exercise or emotional stress, has a shorter duration, is relieved with rest, relieved with medication. Yes, unstable is not. One other kind of wild card is called variant. It's also called Prinz-Metal's angina. Prinz-Metal's angina is pain at rest with ST segment elevation changes or ST segment changes, which would indicate probably a heart attack, but it's thought to be more related to coronary spasms. And this can be corrected by other means. It may not be fully related to prior blockage. It could be related to other vascular issues causing spasms. It's a little more complicated treatment, but your need to know your most common questions you're going to see on your exam and what comes up a lot on NCLEX is stable versus unstable angina. Need to know the difference. There is another thing they talk about. It's called silent ischemia. This is basically heart changes and heart ischemia with that only shows up as ECG changes and lab changes, but does not have any pain with it. This is something you might see more with women. Silent ischemia. Typically, you see the traditional signs of chest pain and symptoms with men. And so this just breaks down the types of ischemia a little bit more. Basically, stable is saying there is some blockages, but we're not at this stage of getting cardiac ischemia where there's tissue death. So maybe we can fix it by changing diet, that sort of stuff. Again, the unstable is there is a blockage that is definitely blocking blood flow, and it's more unpredictable and it doesn't get resolved with rest and meds. And this is, I'm either having a heart attack for sure right now, or it's a precursor to I'm about to have a heart attack. And then the vasospasmic angina is the Prinz-Metal's variant angina that's usually related to blood spasms or other blood vessel disorders. So symptoms, these are always going to be need to know, but kind of the basic summary is the substernal chest pain that so right underneath the sternum chest pain that may radiate to the arm or to the jaw, usually the left arm, left side of the jaw. And some presentations other than that varies. So pretty much the bog standard is going to be chest pain and chest pain with radiation to the arm and jaw, along with losing your color. So having pallor, a cold sweat, cold diaphoresis, and feeling of lightheadedness, dizziness. Those are all like the very bog standard chest pain symptoms. And then some presentations may vary. So, especially for women tend to have more insidious kind of non-specific symptoms of like minor indigestion, nausea, dizziness, lightheadedness. And that's why it is interesting to note that heart attacks are less common in women, but more commonly are deadly because women tend to be tougher and they ignore the symptoms and kind of keep through it. And then they're going to have significant myocardial tissue injury before they seek help. Also, to throw in there, trouble breathing. So, dyspnea, increased respiratory rate, also very common. The assessment wise, there's a little acronym that kind of helps summarize it. NOPQRS, which is basically saying no PQRST. So normal, is this normal for you? When did this pain onset? Was there precipitating factors? Were you gardening? Were you walking upstairs? Were you stressed? Quality and quantity for the Q is talking about what type of pain it is. How would you describe it? Sharp, stabbing, dull, achy. Region of radiation is where does it hurt? Does it radiate to the jaw? Does it radiate to the shoulder? Does it radiate somewhere else? How severe? Scale of 1 to 10. And then time, how long has it been going on? So here's another need to know medications. Traditionally, for a long time, it was like morphine first. And then now the research is kind of saying that if you were going to pick a drug first, you could go with aspirin. But for us, and where the book kind of goes, they go to the ONAM acronym instead of MONA. ONAM is basically saying the problem for the patient is that their heart is being deprived. Their myocardium is being ischemic, it's deprived of oxygen. So if the easiest thing we can do is put them on oxygen, 2 liters of O2, easy enough. So oxygen, then nitroglycerin is a nitrate, it is a vasodilator. It should vasodilate, mean opening up those blood vessels and hopefully regain some blood flow to the deprived tissue. Then you're going to go with the aspirin, and not baby aspirin, a full dose aspirin of 325 milligrams. Aspirin is a platelet aggregate. It keeps more platelets from sticking together, keeps the platelets from being less sticky, and hopefully from the clot getting worse. Along with us vasodilating, we may be able to keep blood flow open to that. And it has been shown with studies, definitely aspirin has been decreases the risk of death from a myocardial infarction. And then last on the acronym is morphine. Morphine is great for pain, and it also helps with oxygen demand and air hunger. It's going to reduce O2 demand, but this is kind of last. Usually a lot of initial orders are going to be give them the aspirin, give them the nitro, put them on oxygen. If nitro really affects blood pressure, it definitely drops blood pressure fast. And so that's why you can only do 3 doses of nitro every 5 minutes. And then after that, you got to work on other things. And so potentially morphine will drop blood pressure too, but we could go to morphine if the pain's not resolved with aspirin and nitro. Other meds that could be part of the regimen: beta blockers decrease heart contractility, decrease blood pressure. We want to hold beta blockers if blood pressures, or excuse me, if heart rate is lower than 60. Usually most beta blockers are going to affect heart rate a lot. And so if heart rate's less than 60, we can't really do beta blockers. Amlodipine is a calcium channel blocker. It's also going to decrease heart rate and O2 demand. And then heparin and platelets or anticoagulants, other antiplatelets like Plavix or Eliquis, anticoagulants like heparin are going to kind of decrease the new formation of a blockage. So the patient's diagnosed with angina pectoris. They complain of experiencing chest pain, frequently even at rest. The period of this pain is longer, takes less stress for the pain to occur. The nurse recognizes this patient is describing which type of angina. I don't have as many questions in these. Sorry, guys, a little bit behind, but some of the questions baked into it. This is what? This is unstable, right? This is right. Chest pain more frequently, even at rest. Ding, ding, ding. Even at rest, that's your key for unstable. The period's longer. It takes less precipitating factors to the pain occur. So that's unstable. So diagnostics, definitely a 12-lead EKG is one of the biggest things. Typically ischemia, one key sign, we'll talk about ST segment changes, but one big sign is that T wave, the repolarization gets messed with when there's part of the tissue of the ventricle specifically that may not be getting the oxygen it needs. And this is called T-wave inversion. Basically, the isometric line here, where there is no electrical activity, the T-wave starts to invert and go down. And this is basically like the polarization signals are off. And this is some more details. In-STEMI versus STEMI. This is real simple, but this is what you want to know about this. What you need to know about in-STEMI and STEMI is that what's a non-STEMI is what in-STEMI means. So STEMI versus in-STEMI, all STEMI means is ST, elevated myocardial infarction. Non-STEMI just means non-ST segment elevated myocardial infarction. Infarction again means that injury to cells. Infarct means if something infarcts, it is injury specifically usually to muscle cells because of ischemia. ST segment elevation, basically a STEMI indicates a more severe destruction of myocardial cells versus non-STEMI could still be a heart attack. It just means usually less damage. So when you hear STEMI, the reason that shows up is that there's more physical damage to the cells of the myocardium than there is with a non-STEMI. Stress tests, talked about this before, but the need to know for an exercise stress is trying to show how the heart works during physical activity, reveals problems with blood flow within the heart. And usually this is done by walking on a treadmill, riding a stationary bike, and then we monitor heart rate, blood pressure, and cardiac rhythm and breathing while this happens. And if someone was started having chest pain and heart attack-like symptoms while having a stress test, we would stop it. Chemical stress tests would be doing it with someone that can't ambulate, someone that can't do the exercise, and then use a medication to induce the same cardiac effects. And typically, we don't want people taking their normal blood pressure medicine or any medicines that's going to mess with their heart before a stress test. We want a kind of raw experience of what their heart's going to do when we put them under some physical stress. Cardiac biomarkers are the ones I've talked about before in chapter 21 with assessment. Troponin, that's the protein we find inside the cells of the muscle. This is the highest known sensitivity, troponin. So troponin is kind of the first choice to know. If troponin is more than 0.04, that's indication for muscle injury. CK, creatine kinase, is an enzyme that's also found in heart muscles or in muscle. And so that over a 24-hour period, we'll measure that. That could spike. And then CKMB is just a subtype of CK that they also monitor. CK and CKMB, if you see those, they're basically enzymes that we would not expect to see high levels in. There should be pretty much zero. So if we see levels of that in the blood, then it indicates cardiac injury. Myoglobin is another protein that helps us store oxygen inside the muscle cells, especially the cardiac muscle, because it's so oxygen dependent that we need a special protein to help with that. And so if myoglobin starts showing up as well, it should be zero. If that shows up, then indicates cardiac injury. And the cardiac cath talked about in chapter 21, but that's placing a catheter into the arteries around and being able to visualize it with a dye, a contrast, also known as an angiogram, and a contrast dye, and visualize the coronary arteries and find and discover those blockages, and then hopefully maybe fix them. And this is just showing you kind of changes as someone has chest pain and angina over an EKG strip. You can kind of see that before the pain, there's already some slight changes. And then as the pain occurs, there's a spike and a change in rhythm where the QRS complex is the same, but that ST segment starts to change. And then as pain is gone, it starts to normalize. So if you're assessing a patient that has angina pectoris, they have history of angina, chest pain, it's important for the nurses to gather what information. So A, B, C, or D. It's kind of a prioritization question. See what you think. If you went with this one, the patient's symptoms B, and the activities that precipitate the attacks, we need to know, is this caused with activity or what exertion, stress? What's the cause? What's the causing agent here? So if I'm administering sublingual nitroglycerin is given under the tongue and dissolves. The most important parameter to assess. I mentioned this, but when you hear nitro, you have to think, I have to know some kind of specific vital sign with this patient. So if you thought blood pressure, you're 100% right. I have to know blood pressure before I administer nitro. So let's talk about the heart attack, myocardial infarction. Sometimes this is also known as acute coronary syndrome, ACS, acute coronary syndrome. Is kind of discussed about someone's having a heart attack or ACS protocols, that sort of stuff. This is emergent. This is an emergency. There's no blood flow or partially occluded plus vasospasms to a section of the myocardium. This can be either the non-STEMI or STEMI, but this is the problem. And it has other manifestations. Again, we talked about some of these symptoms, but lightheadedness, dizziness, pain that radiates to the jaw, to the back, to the shoulder, to the arm, trouble breathing, increased respiratory rate, upset stomach, indigestion. Chest is going to feel pressure or full or like an elephant sitting on my chest. Skin color, pallor, cold sweat. Sometimes with women too, heartburn, cough, palpitations, anorexia. So there is some difference between men and women. Typically, men are much more traditional. They may have nausea and vomiting, but the men are much more traditional. Pain, chest, radiates to jaw, neck, or shoulder, arm, shortness of breath. Women will have all those too, but potential for more of the fainting, dizziness, syncope, indigestion, extreme fatigue, anorexia, those kind of symptoms. Diagnosing, kind of talked about this as well, but this is 12 lead EKG. We're looking for ST elevation, ST segment changes to STEMI, non-STEMI, labs, troponin, myoglobin, CKMB. The troponin is going to be kind of the first to show up usually, and it can peak for weeks. Troponin can stay elevated for weeks. And do keep in mind, as you'll learn other systems and body system and diseases and disorders, that troponin is one of those proteins that we find in all muscle cells, including skeletal muscle. So if someone has severe skeletal muscle injury from a condition like rhabdomyolysis, you might see elevated troponin, and they technically haven't had a heart attack necessarily, a traditional myocardial infarction that we think of. But so myocardial infarction intervention. Typically, you would refer to this predominantly when we talk about intervention. We're talking about going to the cath lab. We're going to get a catheterization. A lot of times, they're more referring to this as this is the what I just blanked. PCI. Why did I just? Sorry, PCI is what they're talking about here. This is percutaneous coronary intervention. Percutaneous coronary intervention. So when someone says PCI, they're talking about a cardiac cath. One of the things we can do, if it's just one artery that's clogged, what they can do is they go in, visualize it, see, okay, this artery is almost completely occluded or very clogged with a plaque, with atherosclerosis and some arteriosclerosis. They can insert their catheter all the way to the site that has a balloon in it with this mesh around it, and they can inflate the balloon. And then once they embed this mesh into the wall of the artery, they'll deflate the balloon and pull it out, and they'll leave the mesh in place. That's called a stent. This stent is hopefully trying to keep the artery open, keep blood flow happening. That's stent placement. And they can do multiple stents depending on the situation. But if we're talking about multiple arteries, 100% occluded, they may go into open heart surgery, and we'll talk about a CABG later. But stent placement with a PCI is what you're talking about. When you talk about doing a cath and they did a stent, that is PCI, that is percutaneous coronary intervention. So again, STEMI versus non-STEMI, this is need to know. STEMI is evidence of EKG changes, the ST segment elevation on a 12 lead, and this just basically indicates much more severe cardiac tissue death. Non-STEMI is saying that they have elevated cardiac biomarkers, they have symptoms of a heart attack, but there's no definitive EKG changes. And this would indicate less severe myocardium damage. Still a heart attack, still problematic, but And then again, showing a ST segment. This is great ST segment elevation, but it depends. It's going to look a little different depending on what kind of thing you're looking at. But you can see it formulate here. On a 12 lead EKG, it just kind of depends. You're not needing to be able to identify that this time, just trying to show you what it kind of visualizes. There's some landmarks of a 12 lead. I think you're not advanced enough for this yet. I'm not really advanced enough for this. I'm not a cardiac nurse. I'm not a cardiac NP. This takes some more thought process, but what it is showing you is that on an EKG, when a really good, well versed doctor is looking at this and they're trained to identify this stuff, and if you work in cardiac, you'll learn to start being able to identify these things. I never was that adept to cardiac monitoring in the sense of I could read a 12 lead EKG and tell you where they're having a heart attack, but they can look at the location and know that which section of the heart might be affected wherever the change happens. And so again, ST segment elevation indicates more myocardium damage from infarction, is a little bit scarier, but both are heart attacks. Both can lead to damage. Again, the run through of what we're going to do is kind of the ONAM. We're going to do oxygen, we're going to do nitro, aspirin, morphine. Again, you can make an argument for aspirin being first over nitro, but nitro is a vasodilator and the blood pressure can handle it. It should alleviate the pain. And morphine's there if we need it. So then this is kind of showing reperfusion therapy, or PCI, the percutaneous intervention. Just kind of showing this to you again so you get an idea of the specifics of what's happening. But as long as you have an idea that when someone goes for a cardiac cath and they put a stent in, it's PCI. So a triage nurse in the emergency department assesses a 66-year-old male patient who presents that ED complains of mid-sternal chest pain, has lasted for 5 hours. If the patient's symptoms are due to an MI, what will happen to the myocardium? It's definitely not D. That's a little bit morbid, but oh, sorry. But yeah, it's going to be the first one here, basically. If this develop, it's going to develop increased infarction. This person, because they waited 5 hours since the pain started, there's much more risk of complete eradication of myocardium and then scar tissue development, because cardiac muscle tissue is very unique. It's its own muscle type, and it doesn't tend to come back once it's completely dead. So the more muscle cells we lose of the myocardium, the riskier we have for secondary conditions like heart failure and just overall cardiac dysfunction. And that's the risk with a heart attack. It's very serious. It's not something to wait around on, because heart muscle equals time, basically. Same thing with strokes and brain tissue. It equals time, basically. The more time that passes before treatment, the more risk it is for that. So after a heart attack, nurses were thinking, are they having surgery? Are they having a procedure done? Are they going to be in the ICU? Are they going to be in another unit? We got to think about discussing activities of daily living. How functional are they? Can they do stuff without working their heart up too much? Changing their diet, making sure they're able to pee and poop for everybody. Psychological support in the sense of I just had a heart attack, I almost died, those kind of things. Risk factor reductions along with exercise, what exercise they can tolerate. Things like cardiac rehab. Talking about diet, what's included in a NA, which is sodium restricted diet. So typically, some of the diets for cardiac patients, you kind of talk about either NAS, no added salt, or you just call it a heart healthy, you call it a cardiac diet, you can call it whatever, but they're pretty much all those are the same. They follow the same pattern. So which one of these is included in that diet? Give you, yeah, it's pretty easy. It's fresh fruit. So frozen dinners full of sodium to preserve them. Canned vegetables, high in sodium. Deli meat, pretty high in sodium as well, and not very lean, decent amount of fat there. So what are they looking to eat? So if you want to summarize a heart healthy diet, it's fresh fruits, fresh veggies, so frozen vegetables if possible. Avoid highly processed foods like frozen dinners, canned vegetables. Avoid high sodium options. Need really lean, low fat proteins, low fat dairy, whole grains, and just no extra added salt. Like no pouring salt on your dish, that kind of thing. So cardiac rehab, just to mention that, comes in some phases, but it's there to treat the patient after a coronary event. Cardiac rehab is basically trying to get them physically active again and figuring out what they can tolerate. And then it's about doing sessions where they undergo some physical activity a couple times a week, usually for the first month or two after a coronary event. And while they're doing that, they're supervising their vital signs, supervising the ECG, and then trying to maintain cardiac stability by following medication and diet regimens. That sort of stuff is kind of phase 3 of it. But that's what cardiac rehab is about. We're not fixing the heart, but we're rehabbing the overall system. Interventions and procedures, we talked about cardiac caths. Arthrectomy is where they actually remove the plaque, and then coronary artery bypass. CABG is what this is short for. This is a good need to know. So CABG, CABG is, I don't think you actually would pronounce it cabbage, but everybody calls it a cabbage. So what is a cabbage? Cabbage is an open heart surgery. When someone has open heart surgery and they have too many clogged coronary arteries to fix with PCI, then we got to do a cabbage. We got to open them up. So they do a medium sternotomy. They cut down the middle and cut open the sternum and retract the ribs and pull the whole chest open. They have to connect the patient to what's called a cardiopulmonary bypass machine. Some people call it a bypass machine for short. And that's going to do the work of breathing and flowing their blood that their heart and lungs would be doing. And then they're going to find a blood vessel somewhere in the body, usually the great saphenous vein, which is a big, thick vein, an artery from the mammary, in the chest, wherever, usually the saphenous vein. They're going to take that vein, cut it down to size, and basically bypass wherever the blockage is. They're going to go above. They're going to go, the graph is going to be kind of proximal to the blockage, distal to the lesion, and they're going to bypass the obstruction. They're going to be proximal to the origin of that artery that's blocked, and then bypass it and plug it into where it's supposed to go, whether that's typically somewhere around the aorta, somewhere in the superior aorta. And they're going to have a lot of drains after this, maybe chest tubes. They're going to suture the chest closed. They're going to have a big wound on their chest. They're going to go to the ICU after this. And there's single, double, triple, quadruple. There can be quadruple bypass. I've never really heard of anything more than 4 of the arteries, but because there's 4 main branches of arteries. There's a few smaller branches, but there's 4 main branches. So if all of those are clogged, they could bypass all 4. And it is a big deal. This is a big open heart procedure. Big deal. Again, they have to open their chest up, retract the ribs, pull everything open so they can see, connect them to the pulmonary, the bypass machine, and then also go to the vein, wherever they're getting that, and take an artery or a vein and replace that. I'll go around the occlusion basically. So pre-procedure, I mean, they're definitely going to be NPO. They need to be assessed, watching for any increase in their symptoms before surgery. Full body scrub. Infection's a huge risk opening the chest up like this. Got to clean everything, make sure the client and family teach, and they're going to have just so many lines afterwards, like cardiac monitor, art lines, swan gauze catheter, IV lines, and pumps full of different cardiac drips. They're going to be intubated, endotracheal tube, on a ventilator for the first little bit after surgery, usually Foley catheter, NG tube, chest tube to remove drainage around the chest after they tried to clean the chest out. Pacing wires, or wires put into the heart to monitor the pace and rhythm. Restraints, if there's so much stuff. I mean, so many things that get dealt with post procedure. Post ops, definitely about using deep breathing and coughing is a big deal to keep lung movement happen. Ambulation is important to kind of keep the heart working, keep blood flow, keep all the other body systems happy. Going to have that big mid-sternal incision that's going to need time to heal. They're going to probably have incisions somewhere where they took the vein from. If it's in their leg, it's probably the great saphenous, but they're going to have somewhere a wound for that. And then medication therapy, there's a lot. We can do the antiplatelet stuff like aspirin, Plavix, Eliquis, beta blockers, metoprolol, labetalol, calcium channel blockers, amlodipine, nitrates for PRN pain after this, nitroglycerin, ACE inhibitors, lisinopril, enalapril, all those guys, hyperliptics, antipyretics, anti cholesterol meds, all that sort of stuff. Which complication of a cardiac surgery occurs when there's fluid and/or clot accumulation in the pericardial sac, which compresses the heart, preventing the blood from filling the ventricles and basically preventing the heart from pumping effectively. This is cardiac tamponade, letter A up there. Cardiac tamponade is something to kind of keep in mind. This is a bigger risk with these open heart surgeries because they have to go in and they're going to clean them out. That sort of stuff is potential for fluid shifts to happen after the chest has been open and fluid to shift into the pericardial space, which suppresses the overall pumping ability of the heart and eventually could lead to cardiac arrest if it's not corrected. And they could do a pericarditis. I can't even talk. They could go in and actually put a needle in there and remove part of the fluid out of the heart to correct this. The nurse caring for a client who's CABG, post-op day 2 from a CABG. The client has a nursing diagnosis of impaired gas exchange. Which action would the nurse take to best assist this client with the diagnosis of impaired gas exchange? So this one's a tough one. I would say the correct answer here is probably B. The simplest way is to make sure they're using a incentive spirometer. That will make them deep breathe and some coughing. We don't want to focus on making them cough necessarily. We can avoid it. They have a large chest wound that's going to be sore, and we don't want to make them cough necessarily, but we want them to deep breathe. And the incentive spirometer is the best way to do that. We could auscultate their lungs twice a shift, but that's an assessment, not really an intervention. And then pre-medicating before ambulating really wouldn't have much to do with this. So. Part 2 of this is real quick. It's kind of this one also kind of summarizes the stuff we already talked about with this. So I'm just kind of running through this. These are some videos around kind of angiograms and that sort of stuff. I think they're pretty helpful, so I'll let them play out just for this section of kind of part 2 of chapter 23. Making sure sharing sound, yeah. So we'll let them play through here.
I'm Dr. Eric Cohen. I want to talk a little bit about coronary angiogram for information of patients who might undergo this procedure. First of all, coronary angiogram is a type of X-ray picture of the arteries of the heart. You can see on our model of the heart right here that these red lines are the arteries, the tubes that take blood to the heart muscle itself. And as you probably know, these are prone to getting narrowed or blocked. And the angiogram is about looking for those narrowings and blockages. What we do in an angiogram is insert a tube through an artery in the wrist or sometimes at the top of the leg, thread it up to the heart, and then inject X-ray dye into these arteries here. The X-ray dye then outlines for us where the arteries are blocked. And based on what we find on those pictures, we then decide what, together with the patient, of course, what the best treatment might be. And various treatments include medications alone, sometimes bypass surgery, and sometimes the balloon procedure with a stent, which we call angioplasty, or these days we call it PCI.
How are you doing?
Good, thank you.
Good, okay.
On the day that we do the procedure, many patients come from home that morning, and if we're just doing the angiogram procedure, they usually go home the same day. It's an outpatient procedure, often home within a few hours. We usually ask you to not have anything to eat in the morning if your procedure is scheduled early in the day, and if it's scheduled later, you can have a light breakfast before showing up. So here you see Mr. Nazim coming into the procedure room. He's being led to the procedure table. The nurses will do some prep of the skin on the hand and at the top of the leg, and then we usually insert some local anesthetic, a very small amount, a little bit of discomfort with that, but once it's numbed up, usually don't feel anything else. And you are awake during this procedure. We often use some mild sedation, so you're a bit relaxed, but we do not need a general anesthetic. You don't need to be asleep for this. In fact, many patients can watch on the monitor exactly what's going on. And following this, we proceed to insert what we call an introducer tube. The introducer tube is in place now. We advance the catheters towards the heart, and we are guided by the X-ray during this. You can see that people in the room wear X-ray protection in the form of a lead apron, and there are X-ray shields. This is mainly to protect the staff who are exposed to the X-rays constantly in their job. Here you can see we are actually injecting the X-ray dye and taking the pictures, and the images are shown in real time on the monitor. We're observing the monitor. We take multiple pictures from different angles. That's why you see the camera being moved around to different projections. Once we've seen the images, sometimes we will proceed with the angioplasty procedure. That's the balloon and stent, right then and there at the same time. In other situations, it requires further discussion, thinking about it, and as I said before, possibly other types of treatment. After the procedure, you're taken off the procedure table, wheeled back to the room, usually on a stretcher, sometimes in a wheelchair, and then we usually keep an eye on things and observe for 3 to 4 hours, sometimes a bit less if it's an uncomplicated procedure. And as I said, you go home the same day. We always ask you to take it easy that evening when you go home. But one of the advantages of this kind of procedure is you can get back to your usual activities very quickly. If we do the angioplasty procedure either at the same time or even if you come back for it on a separate day, that takes a bit longer for the procedure itself, and that depends on how complex your particular arteries and situation might be. We've completed taking the pictures and we're reviewing them now and discussing with Mr. Nazim what the best treatment option would be. Put at least one, but maybe 2 stents there, and that will probably make your chest discomfort feel better. And in this case, we all felt that an attempt to open that narrowed artery right away would be the best treatment option. So we're getting set up at this point to proceed with what we call an angioplasty or a stent procedure. We've started working on the angioplasty at this point. We use a very fine guide wire which is threaded through the narrowed area of the artery, and then we insert a small balloon. Everything is very small here. The arteries themselves are only 2 or 3 millimeters in diameter. We insert the balloon and then we inflate it to stretch the artery a bit. That makes room to bring the stent in, and in this case we required more than 1 stent to fully open the narrowed portion of the artery. At this point we've completed the procedure, the stents are in place, and it might be quite obvious from the images that the artery is now wide open where it was severely narrowed before. At this point we just have to remove the tube, the introducer sheath, from the wrist. We apply pressure over the site until the bleeding would stop. And you can see that there really is very little blood loss, and the only incision made is about 1/4 of an inch in length. So you want to see the picture before and after? Yeah. See, it's almost completely blocked. There's no blood getting through. And afterwards it's wide open. Lots of blood getting through. Okay? So that's called the right coronary artery. The bottom, it's the right and bottom part of your heart. And the whole bottom part of your heart was not getting very much blood supply. So I think your angina is going to feel better. Once we're all done with removing all the equipment, the patient is taken off the procedure table. He's getting back onto a stretcher here and will be returned to what we call the short stay unit. He may go home later in the same day, or in this case, because it was later in the day already, he'll probably stay overnight and go home the following morning. We usually arrange or ask that you arrange follow-up with your own cardiologist, who might be someone here at Sunnybrook or might be somewhere else. We make sure that you have all the information about prescriptions.
Okay, so it's a good video. Summarizes a lot. So CABG. So CABG again is coronary artery bypass graft. So we are bypassing blocked arteries because there's the PCI doesn't work sometimes if there's too many areas of low blood flow, the arteries are damaged too much, there's too many, 3, 4 different arteries affected, then you have to go to the CABG. And that's again opening the chest up, that sort of stuff. Got a video on that as well. I think it's a good video, and then we'll kind of finish that discussion.
Hi, I'm Dr. Deborah Sambucci with the Heart House. I received my medical training at the University of Medicine Dentistry of New Jersey and have been treating people with cardiovascular disease for the past 8 years. This program was created to help you understand how and why a coronary artery bypass graft, or CABG, is performed. The video you are about to see will help you understand the steps of a coronary artery bypass graft or CABG procedure, 3 different types of bypass surgery, and what you may expect before and after your procedure. If there is any information you need repeated, you can watch the video as many times as you wish. Please share this program with family and friends so they can better understand your coronary artery bypass graft or CABG procedure and provide you with support. Let's start by learning how the CABG procedure creates a new path for oxygen-rich blood to flow to the heart muscle.
If you or someone you know has recently had a coronary artery bypass graft, or CABG, this video will help you understand the steps of the procedure and how it restores blood flow to your heart. A coronary artery bypass graft, or CABG, is performed to improve circulation to the heart muscle. In this procedure, a healthy artery or vein from another part of the body is connected or grafted to the blocked coronary artery. The grafted artery or vein bypasses the blocked portion of the coronary artery, carrying oxygen-rich blood to the heart muscle. 1 or more coronary arteries may be bypassed during a single operation. Before the surgery, an intravenous line will be started, and you may be given a medication to help you relax. CABG procedures are done under general anesthesia, which will put you to sleep for the duration of the operation. A breathing tube will be inserted through your mouth and into your throat to help you breathe. A catheter will be placed in your bladder to drain your urine. Coronary artery bypass surgery generally takes 3 to 6 hours. During a conventional bypass surgery, your surgeon begins by making an incision in the skin over your breastbone or sternum. He or she will then cut the sternum and move your rib cage in order to get to your heart. Throughout the procedure, your circulatory system may be connected to a cardiopulmonary bypass pump or heart-lung machine. This machine may temporarily perform the functions of your heart and lungs during the surgery, allowing your heart to be stopped if desired, while the surgeon sews the grafts into place. Different blood vessels may typically be used for the grafts: the internal thoracic arteries in the chest, or the saphenous veins in the legs. For the internal thoracic artery graft, your surgeon will leave the upper end attached to the subclavian artery and divert the lower end from your chest wall to your coronary artery just beyond the blockage. Your surgeon will then sew the graft into place. For the saphenous vein graft, your surgeon will suture one end to the aorta and the other end to the narrowed artery just beyond the blockage. With the graft securely in place, your surgeon may use electrical signals to restore the heartbeat and attach a temporary pacemaker to the heart. Once your heart is again beating normally, if the surgeon used the heart-lung machine, it would be disconnected. Your surgeon will wire the breastbone back together and suture the skin incision closed. A temporary drainage tube will be placed through the skin beneath the incision. When the surgeon chooses to do the surgery without using the heart-lung machine, the heart continues to beat. This may be referred to as off-pump bypass surgery or minimally invasive surgery. Instead, a mechanical device is used to steady the part of the heart where grafting is being done. Surgeons perform minimally invasive bypass procedures using specially designed instruments inserted through small incisions or ports in the chest. After surgery, you will be taken to the intensive care unit. The activity of your heart will be carefully monitored. If necessary, the pacing wires will be used to temporarily control your heart rate. The chest tube will remain in place to drain excess blood and air from the chest cavity. Once you can breathe on your own, your breathing tube will be removed and replaced with an oxygen mask. The bladder catheter will remain in place. As you recover from surgery over the next 3 to 5 days, all of these devices will be gradually removed. Upon discharge from your procedure, be sure to contact your doctor if you have any questions or experience any side effects.
All right, moving on. So CABG, big deal. Again, coronary artery bypass surgery, big deal. Chest being opened, maybe on a bypass machine. Again, this is kind of reiterating some of the stuff from the other chapter, but just kind of giving you the videos for it. Post-op, again, connected to a lot of tubes. Ambulation and using of sinus barometer is important. Infection control with the wounds that you may have or the patient may have are big. And then blood medications the same: antiplatelets, beta blockers, calcium channel blockers, nitroglycerin, maybe ACE inhibitors, similar. So that kind of wraps up everything with chapter 23. And yeah, we'll move on to hypertension and our heart failure, hypertension, and other cardiovascular disorders.